So in our next session, we will see that can behavioral science techniques prevent or reduce violence in healthcare settings? A pilot test in 2 hospitals in Pakistan. According to WHO, between 8 to 38% of health workers suffer physical violence, while many more are threatened or exposed to verbal aggression. To draw attention to one of these silent epidemics that has become increasingly prevalent, I would like to invite Dr. Mirwais Khan, who is the head of Healthcare in Danger with ICRC in Pakistan. Once again, please bear with the interruption of 5 minutes heads up before the end of your designated time. Over to you, Dr. Khan.
Thank you. I'm Dr. Mirwais. I'm the head of the Healthcare in Danger initiative, the HCID initiative of the International Committee of the Red Cross, the ICRC in Pakistan. My presentation today is a brief overview of a randomized study in 2 hospitals in Pakistan using behavioral insights to prevent violence in healthcare settings. Can you see my screen?
Yes, we can see it all right. Probably could maximize it if that's okay.
Yep.
Perfect.
So this study, this project, it's a collaboration of 5 institutions. The ICRC has joined hands with the Swiss consultancy firm, Policy Analytics, the Indus Hospital in Karachi, and Khyber Medical University and Hayathabad Medical Complex in Peshawar to conduct this study. This study is being undertaken under the framework of the ICRC's Healthcare in Danger initiative, which is a global initiative which commenced in 2011 and is aimed at increasing the protection of healthcare from violence. The initiative works in 3 distinct but interconnected areas, including raising the awareness regarding respect of healthcare, promoting and strengthening national responses for protection of healthcare, and mobilizing a broad community of concern to promote measures to increase the protection of healthcare. At a practical level, the initiative engages in humanitarian diplomacy, advocacy, raising awareness, promotion of law, and promotion of practical measures and other initiatives for increasing the protection of healthcare personnel, patients, medical transport, and healthcare facilities. To provide a perspective, a background for the current study, violence against healthcare is a global humanitarian concern and remains one of the priority areas of intervention for the ICRC. For a humanitarian actor like the ICRC, it is a matter of grave concern that the traditional neutrality and respect accorded to healthcare has been repeatedly violated, more so in situations of armed conflict and other situations of violence. However, the problem remains ubiquitous across varying healthcare settings due to a number of reasons. The work conducted previously under the Healthcare in Danger initiative of the ICRC in Pakistan has revealed the magnitude of the problem in healthcare settings in Pakistan. In a baseline study conducted in 2015 in Karachi, we found out that over a period of just 1 year, as many as 65.6% of healthcare workers had either experienced or witnessed violence at their workplace. When a similar study with the same design was repeated in Peshawar, another city of Pakistan, we found out that more than half the healthcare workers had either experienced or witnessed violence. And then a similar design was employed to conduct a study across 16 cities of Pakistan, in which more than 8,500 healthcare workers participated. And we found out that over a short recall period of just 6 months, more than 49% of healthcare workers had either experienced or witnessed violence. We also found out that the most common sites of violence against healthcare in healthcare settings remained emergency departments and emergency physicians and emergency medical services providers remained the most frequently affected cadres of healthcare workers. We also found out that patients and their attendants were the perpetrators of majority of these incidents of violence against healthcare. By attendants, I mean all those family members, friends, relatives who accompany patients during their consultation in hospitals. The previous work conducted in the initiative also identified the need to influence behaviors and the need to design behavioral interventions based on some of these insights. For us in this study, the research question is, what is the impact of behavioral interventions in prevention of violence in healthcare settings? This is a two-phase study, and in both the phases, there were distinct objectives. In the initial phase, the main objective were the identification of main drivers of violence, and then based on the understanding, designing behavioral interventions. The second phase of the study is concerned with the testing of the behavioral interventions identified and designed in the first phase to see their impact in terms of reduction of violence by hospital staff, patients, and their attendants in emergency departments at two hospitals in two cities in Pakistan. It is also important to remember that the interventions were co-designed with staff in the emergency department and were based on inputs from patients, attendants, as well as using insights from behavioral sciences. The ethical approval for the two phases of the project were obtained from the Ethical Review Committee of the Institutional Review Board of Indus Hospital in Karachi. It was also made sure to obtain administrative approval from the management of the two hospitals. This is a mixed method study with both qualitative and quantitative data being collected. As I mentioned, the study has two distinct phases, and the focus of the first phase was understanding the main drivers of violence, for which the methods of process mapping, baseline surveys with patients, attendants, and staff, in-depth interviews and focus group discussions with relevant stakeholders were held. And based on the data that was gathered, the insights that were gathered during these methods, we held two design workshops with the staff of the emergency department to co-design behavioral interventions. The second phase is about analyzing the impact of the behavioral interventions. Selected interventions are currently being tested in the emergency departments of the two hospitals, and online data collection will be undertaken to analyze the impact of these behavioral interventions. The selection of sites for the study was based on a set criteria, which included that the violence in the emergency departments had to be an established and worrying phenomenon, that there had to be a relatively high patient footfall in the emergency department to represent a typical Pakistani tertiary care emergency department setting, and that there had to be a willingness of the hospitals to take part in the study, and no previous such studies on interventions had been previously conducted at these sites that could pollute the findings of the current study. Now I'd go into slightly more details of the various research methods that were used in the first phase. The first thing that we undertook was process mapping. Process mapping was kind of follow-up of the individual patients and their attendants' journey in the emergency departments of the hospitals. 124 patients were followed at Indus Hospital, and 130 patients were followed in Hyderabad Medical Complex. The process map enabled us to describe the workflow, the flow of the patient, to develop an understanding of the processes that were involved, to understand the attendants' understanding of triage, complaint registration mechanism, the various ER processes that were involved, and more important, to identify those factors that were responsible for triggering violent or aggressive behaviors in the emergency departments. The process map also enabled us to develop a visual picture of the processes, the structures that were involved in a patient's journey. And as you can see in this diagram, this is a pictorial representation of the process map of Indus Hospital. The yellow arrows represent the various triggers or the points where aggressive behavior was developing due to various reasons. Besides process mapping, we also conducted baseline survey using a structured questionnaire with 808 attendants and 173 staff members in the two hospitals. The major findings were that the cases of violence reported in Karachi were considerably greater as compared to Peshawar. the understanding of attendants at the hospital in Peshawar was regarding the ER processes was considerably poor as compared to Karachi, and that at both the sites, the majority of the attendants had no idea or understanding of how to formally register their complaints. A standout feature of this finding of the baseline survey with both attendants and staff members was that long waiting times were the main reasons for complaints at both the settings. Besides the quantitative data collection, in the initial phase, we also conducted qualitative data collection. In-depth interviews and focus group discussions were held with attendants and staff members. 10 in-depth interviews using semi-structured interview guide were conducted with staff and attendants at Indus Hospital and Hyderabad Medical Complex. The focus of the interviews were to identify the challenges faced by staff members in the emergency rooms, understanding the concept of violence or the understanding of violence from the perspective of both the attendants and staff, and to understand the structure and setup of the ER from the attendants' perspective. Besides the in-depth interviews, the four focus group discussions, they were conducted with staff members and attendants at both the hospitals, and were mostly to gain further insights into the concerns which came to the fore during the baseline survey that had been conducted with staff and attendants. The
last 5 minutes of the Khan.
Sorry?
Last 5 minutes.
Right. Qualitative results showed a general satisfaction with patient care. However, at both the attendance and staff level, certain aspects that needed improving were identified, such as decreasing workload of healthcare staff, raising awareness regarding ER processes, having a reception desk for more information sharing, and addressing long waiting times, which was once again identified as the biggest trigger of violence. These findings were then shared with the staff of the emergency department to co-design interventions together with them. Two workshops were held at Karachi and Peshawar, and several possible interventions were identified, including information desk, fast-track clinics, direction boards, color coding to make the ER processes more understandable to the attendants. And all these discussions were further discussed with the research team, with the administration of the emergency departments, and were narrowed down into these interventions, behavioral interventions, which fall into two large groups. One centering around commitment of individuals and public to be more respectful towards healthcare. And the other one was the use of information desk. In the attendant commitment device or attendant behavioral intervention, there was a private device where the attendants would sign a pledge to treat the staff with respect, and in turn the hospital staff would pledge the same. This was based on behavioral hinges of commitment and reciprocity. Then there were public pledges that had to be signed by the attendants and the staff, which again were based on certain behavioral insights such as commitment, reciprocity, and adherence to social norms and following behaviors exhibited by their peers. And the information desk, as identified in the initial data collection, it arose from the need to have better information sharing and was based on the behavioral insight of the expectation setting. This is a pictorial representation of the various commitment devices. The top half represent the attendance private commitment pledge, while the left lower quadrant is attendant public commitment device. Similarly, the one in the right lower quadrant of the screen is a staff public commitment device. Now, in the second phase, we have rolled out, we initially piloted the interventions, and now we have interventions rolled out at both Karachi and Peshawar. We would run them in two waves. In wave one, we'd be testing the private commitment device, the attendant private commitment device, and a random sample of 400 participants will be assigned to intervention and control groups. In the second wave, we'll be on alternate days, we'll be testing public commitment devices, information desk, and then on the third day, we would have no intervention. A random sample of 600 participants will be assigned to randomly assigned to each of the operational days. And the important point to consider here right now is that we were supposed to have this finished by now. However, due to COVID-19, the rollout of the interventions was delayed due to COVID-19. The phase 2 data collection would involve collection of some qualitative data and the use of a questionnaire to have inline data collection on the stay and wait time of the attendants and patients in the ER, assessing the understanding of patients regarding the processes involved in the emergency department, their emotion and state of mind, understanding of the conflict, if any, happens during this time in the emergency department, and a continuous behavioral analysis together with gathering some data on the socio-economic background of the attendants who visit the hospital emergency departments during these days. The pilot of the interventions was mostly conducted to see the feasibility and operationalization of the interventions. We had to make certain adjustments in light of feedback from attendants, in light of the feedback from doctors in the emergency department. Initially, we were to assign in phase 1 the participants randomly to both intervention and control group. However, now this randomization will take place on successive days, where one day will be an intervention day and the other day for us would comprise interactions with the control group. There were other findings from the pilot as well, which has helped us in a more simulation of the interventions right now. The planned next steps right now are the testing of the interventions. As I mentioned, it is still in progress, and then there will be an inline data collection at both Karachi and Peshawar. As I mentioned previously, we were supposed to present the findings of the study at this time. However, due to COVID-19, some of the processes got delayed, especially the rollout of the interventions had to be put off. And once that happens, we would analyze the data, write policy briefs and research papers, and disseminate the findings of the research. The research team is also interested in knowing from the participants their experiences, especially during the situation of COVID-19, and if they have other ideas of behavioral interventions in ERs or healthcare settings to prevent violence against healthcare. The violence that I have referred to in my presentation is reactive violence, which is more of a spur of the moment kind of violence, which can happen in any workplace. Violence due to any reason, say communication failure, say long waiting times, less sharing of information. These interventions are primarily directed towards that. This pretty much ends up my presentation. Thank you.
Thank you so much, Dr. Khan, for such a striking presentation. So we have a couple of questions from our audience. Dr. Raj wants to know, is there a specific timeline related to the next step?
Yes, we are trying to finish the inline data collection by the end of this year. Unfortunately, we had to have a lengthy gap due to the emergence of COVID-19 towards late February, early March in Pakistan. So having a lull in the data collection, it kind of dragged the project on for some time. But right now we are aiming for end of this year so that we have the inline data collection over by then.
Thank you. Another question from Dr. Raj. Are there any key insights that you hope to achieve through the next phase?
Yes, one, I mean, I've mentioned about the magnitude of the problem that violence against healthcare imposes on the healthcare system in Pakistan. under the initiative, we are working with a multidisciplinary approach. Behavioral interventions using specifically behavioral insights is one area where we had not ventured so deeply. So one is to have an idea of how kind of quick exposure, minimal exposure interventions, how much can they help in reducing violence in healthcare settings. This is one of the things we look forward to. And then, yes, if that happens, then we would also have to look at how much of the processes can we replicate in other settings within Pakistan and with other teams elsewhere.
Dr. Khan, thank you so much for sharing such intriguing modalities of intervention. I'm confident that the M-Line survey will not only delineate the most effective of those 3 interventions, but also will be replicable. Thank you.
Thank you.